Welcome to APCCMI 2021. If you have just tuned in and this is your first program, my heart out to you. Thank you very much. We're going to jump straight into the next symposium. This is a Pfizer sponsored symposium. We're going to talk about the effective management of cSSTI. The essence is actually bringing the focus back to the patient. And at the end of it, the patient is at the heart of all that we do. I'm Dr. Ho Nam Leong. I'm an infectious disease physician in private practice, calling and hailing from Singapore. Good afternoon to you if you're on the closer to the east side of the world, and a good morning to you if you're hailing from India. I'm going to be the moderator for the symposium. I'm going to go through some disclaimers of the meeting. These are the usual disclaimers. I'm just going to let you fly through it for a couple of seconds. And then I'm going to go through the objectives, which is to share the latest data and guidelines on the management of cSSTI. I'm going to update you on the current practice. We're going to share some experience on the challenges surrounding the diagnosis and treatment, and perhaps we'll try to go a bit more practical ways to overcome the challenges with cSSTI. And the fascinating thing about Zoom platforms or other telecommunications is you can ask your questions anywhere, and there will be interactive audience participation as well. There will be questions and answers, and feel free to answer them. And of course, please post your questions to us. As you see on the slides now, you can see how you can submit questions for the live question and answer. Click on the question and answer on the bottom left, and then type in your question and send. We have about 5 to 8 minutes to answer questions. Please put them up and we'll do our best to answer them. Going forwards, I'd just like to remind you that during the interactive grand rounds, there will be live polling. Please choose your best answers as best they are, and then let us discuss the options available and the responses thereafter. Again, click your option and submit, and the polling results will appear on the screen. Your feedback, of course, is very, very important to us. At the end of it all, there's a QR code. Whip out your camera, fill in the QR code, and give us your feedback, because we need your feedback to improve on the next meeting there is. Now, too much of me. Now to the real speaker. This is a very illustrious professor, Professor Murat Akova. Is a professor of medicine from the Department of Infectious Disease at Hacettepe University School of Medicine in Ankara, Turkey. Honestly, this is where I want to go to now. He's the president of the Turkish Febrile Neutropenia Society and the past president of the European Society of Clinical Microbiology and Infectious Diseases and the Turkish Clinical Research Association. You see, he's very highly well published, and he's also the editor-in-chief for infectious diseases and clinical microbiology. He's the associated editor for the Frontiers in Medicine and a scientific committee member for CMI, Clinical Microbiology and Infectious Diseases. His research interests are on antimicrobial resistance and infections in immunocompromised patients. And of course, he has published extensively in numerous peer-reviewed journals. I'm going to ask Professor Akova to actually give us a little, to share with us on updates on cSSTI, what's ideal and what could be done better. Professor Akova, the stage is yours.
Thank you very much, Professor Leong. This is a real pleasure for me to be a part of this symposium, although only virtually, as you were mentioning during the last 2 years. I mean, we were all exhausted to be in front of the computers only, but I hope in very near future we will see each other face to face and physically again. So a pleasure again, and thank you very much for this very kind introduction of myself. Let me share my slides first and then start immediately. Right. So as Dr. Leong was mentioning, my task is to give you some insights about the current practice for treating complicated skin and soft tissue infections. This is my disclaimer. Well, starting with skin and soft tissue infections, you see it's a satellite of different type of infections under the same title. So it could be a simple cellulitis, or an abscess, or an infected ulcer, infected wound bites, or a very complicated diabetic food infection in severely diabetic, uncontrolled diabetic patients, or most frequently you will come across a surgical site infection, and in the most severe form it would be a necrotizing skin and soft tissue infection. But overall, less than 0.1% of the adult population would require hospital treatment for skin and soft tissue each year, and the disease itself will be complicated if the patient requires hospitalization, surgery, if the infection involves deeper tissues, and there are some comorbidities or systematic symptoms. Oops. Well, if you look at the anatomy, you can classify these infections according to the site where the infection is present. For example, if the only epidermis is involved, you will see different type of infections like erysipelas, impetigo, furunculosis. But as the infection goes deeper, and at the border of the superficial fascia and dermis, you will have cellulitis. And if the subcutaneous fat and deeper fascia are involved, then you will have necrotizing fasciitis. And finally, you will have myonecrosis, where the muscle tissue is also involved. Well, these infections are approximately 10% of all hospital admissions in US data. Mostly these infections are in the lower extremities, and once they happen, they can recur up to 50% of all cases. And among the bacteria, Staph aureus is the most important, most frequent pathogen, and I will detail these pathogens shortly. But necrotizing infections are often polymicrobial and usually involve MRSA, Clostridium species, and group A streptococci. And the virulence of these pathogens is responsible more than 30% of the mortality worldwide, particularly with the MRSA and group A streptococci. Now, let me show you some statistics. These are coming from US, and these paper covers more than 48 million persons years. So this is a comparative graphic. You see the skin and soft tissue, blue line, as compared with UTI and pneumonia. It is much more frequent, at least 3 or 10 times more frequent as compared with UTI and pneumonia. And if you look at the severity of the infection, well, most of the infections would be uncomplicated, but almost the same share will be complicated infections. And this is more than 2.3 million skin and soft tissue infections. The important part is that more than half of these infections will be either an abscess or cellulitis. Now, the age an important confounding factor for defining these infections. So you see in both ambulatory setting and inpatient setting, as the ages increases, so does the prevalence of the infection. So those patients between 45 and 64 years, as compared with the rest of the age distribution, will have higher incidences of skin and soft tissue infection. Now, talking about the causative pathogens, I already mentioned about MRSA and mixed infections. So in different types, for example, in abscesses, MSSA or MRSA are the most important one. Cellulitis, in addition to Staph aureus, you would see different types of Streptococcus species, including Streptococcus pyogenes. And in ulcer, particularly in diabetic ulcer, diabetic food infections, you will see a mixed type of infections ranging from gram-positive bacteria like Peptostreptococci and to gram-negative, severe gram-negative infections like Pseudomonas aeruginosa, a truly mixed type of infection. Now, let's talk a little bit about MRSA. MRSA is the single most important pathogen for the complicated skin and soft tissue infections. And as you see in this map, throughout the world, you can see different types of prevalences for MRSA. And on the eastern part of the world, particularly including this is China, Singapore, Australia, Philippines, Indonesia, the prevalence of MRSA is more than 50%. So this is the most important part of the MRSA causing infections. And in Europe and US, you see varying prevalences, but in US and South America, the figures are very similar to the east part of the world. Now, those infections, when you see the patient in an outpatient clinic, you have to decide what are the indications for hospital admission of this patient. So here are the criteria. First, the patient should be feverish. And then if there are several comorbidities, including vascular insufficiency, neuropathy, diabetes, immunosuppression, elevated CRP or lactate levels, if more than 9% of the body surface is involved, and if there are involvement of the deep tissues, particularly muscle and the facial part, and if the lesion is rapidly progressive and there is a sign of toxemia, each of these factors are one of the criterion to admit the patient to the hospital. Now, I will talk about one of the recent guidelines. This is the Surgical Infection Society 2023 recommendations, which was actually published in 2021. And here are some practical recommendations. The SIS suggested that bedside ultrasonography is very useful to distinguish cellulitis from abscesses. So it should be used in any case, because if you find an abscess, of course, the drainage would be essential. You can actually aspirate, but when you compare aspiration and the incision and drainage, the first one, incision and drainage, would be much more useful. Well, for detecting MRSA, remember MRSA is the single most important pathogen for these type of infections. You can use some rapid molecular tests to identify immediately. So that would give you the results whether the pathogen is a Staph aureus and then whether it's resistant to methicillin, so as to adjust your treatment. And these molecular tests would give you results within a couple of hours. And then finally, the empirical coverage of MRSA is very important, particularly in purulent infections. So 3 important messages. Now, these guidelines use these grading recommendations. So the grading recommendation is stratified between 1 and 2. 1 indicates a strong recommendation and 2 indicates weak recommendation. And there are subtitles as well. So if it's a 1A, this is the most strongest recommendation with high quality of evidence indicating randomized controlled trials without any flaws or any limitations. So this is a very strong recommendation. However, for example, if you go to 2C, this is a very weak recommendation, and the quality of evidence is very low or low quality, which usually indicates only observational studies or case series. So let's have a look at what SIS guidelines suggest us for the empirical antimicrobial therapy for complicated skin and soft tissue infections. So if there is a suspected or confirmed MRSA infections, there are a list of selected IV therapies. And these therapies, as you see here, they are all category 1A. And if you remember from the previous slide, 1A is a very strong suggestion and very high level of quality. So it means that there are a randomized trial, at least comparing these antibiotics and proving its efficacy. So it's vancomycin, linezolid, daptomycin, ceftaroline, and telavancin. Well, here is a subtitle here. Well, unfortunately, some of these antibiotics are not available in Singapore, at least, and in my country as well. But ceftaroline among one of these, which is the only beta-lactam antibiotic among all these. And there are other alternatives as well. And as you see, these are all 1A categories as well, except tigecycline. Tigecycline is 2C category, which means a low quality of evidence and the weak recommendation in here. Now, what are the pros and cons for these selected empirical agents in the complicated skin and soft tissue infections? Let's start with the classical one, vancomycin. Vancomycin is the standard therapy, but I'm going to show you the data. Unfortunately, the efficacy decreases as the MIC in MRSA increases. And it's, lots of side effects related to vancomycin therapy, and the efficacy is only gram-positive efficacy. Linezolid could be an alternative to vancomycin, but it has some sort of toxicity, and again, the efficacy only against gram-positive bacteria. Daptomycin, very similar. It could be an alternative to vancomycin, but only gram-positive efficacy. But Cephteroline, as I already mentioned, that it's a beta-lactam antibiotic, and it's alternative to vancomycin and aztreonam. So aztreonam is a very broad-spectrum gram-negative agent plus vancomycin. So MRSA activity is prominent, and also it has gram-negative activity similar to ceftriaxone. I'm not going to mention in detail with telavancin, and it's not available in Singapore, but it's an alternative to vancomycin and only has gram-positive activity. Well, here is one of the shortcomings of vancomycin, which I already mentioned. This is the MRSA treatment outcome, and you see two graphs here. On the left-hand side, MRSA bacteremia, and on the right-hand side, various indications, including complicated skin and soft tissue infections. And as you see, when the vancomycin MIC is less than 0.5 or equal to 0.5, there's no problem. You can successfully treat those infections, although not all of them, but more than half of them. But as the MIC of vancomycin increases 1 and upwards, you see there is a sharp decrease of the success of the treatment. So this is one of the shortcomings of vancomycin. And here is the most detailed meta-analysis published about vancomycin therapy so far. So this is the failure of vancomycin therapy comparing MICs now not 0.5, but 1.5 and above 1.5. And as you see here, the failure of vancomycin therapy is statistically significant in those trials where the vancomycin MIC is equal to 1.5 or higher than 1.5. This is the mortality. This is the MRSA mortality, and particularly in bacteremic patients, of course. And again, there is a statistical significance, as you see, in those patients infected with an MRSA where the vancomycin MIC is equal to 1.5 or higher than 1.5. So this is the major shortcoming with the MRSA infections. Now let's talk a little bit about the beta-lactam antibiotic, which I mentioned, Cephteroline. Cephteroline is a novel so-called fifth generation cephalosporin. It's called fifth generation because it's active against MRSA. And as we all know that normally none of the beta-lactam antibiotics so far we have been using in the clinical setting has no intrinsic activity against MRSA. Actually using an MRSA infection is a contraindication for beta-lactam antibiotic. But ceftaroline is an exception because it's active against MRSA, vancomycin intermediate staph aureus, and penicillin-resistant Streptococcus pneumonia. So it has a high activity for the penicillin binding protein for these bacteria, and it can be very active against these bacteria. And on the top of that, it has gram-negative activity similar to ceftriaxone. So it has no intrinsic activity against Pseudomonas, but apart from Pseudomonas, it has activity other gram-negative bacteria. It has no anaerobic bacteria. The regular dose is 600 milligram BID. You have to adjust it to renal failure, and it's a very safe drug as comparable with other cephalosporins. So there was 2 trials actually, which was in a single paper. That was a phase 3 multi-center randomized double-blind study comparing ceftaroline versus vancomycin plus aztreonam in complicated skin and soft tissue infections. And that was published in Clinical Infectious Diseases. So I'm showing you here 3 tables. The first is the clinical cure rate. So you see in clinically available patients, modified intent to treat analysis and microbiologically available cases, both gram-positive, gram-negative bacteria, mixed infections, and polymicrobial infections, there was no difference between Cephteroline and the combination therapy. If you look at the individual microorganisms, Staphylococcus aureus, both MRSA and MSSA, Streptococci, different types of Streptococci, E. coli, Enterococcus, well, Pseudomonas aeruginosa, of course, there is no activity, so it's uncomparable. But other gram-negatives, Proteus and Klebsiella pneumonia, you see it's all comparable with vancomycin plus Fastreonam and Cephteroline. And finally, if you look at the different types of infections, from cellulitis to infected wound infections to diabetes mellitus and bacteremic cases, including MRSA cases, the difference is not statistically significant. So Cephteroline is comparable with vancomycin and plus Astreonam. So this is a highly effective agent for this indication. So before concluding, I think I have to mention once again that complicated skin and soft tissue infections are the important causes of morbidity and mortality in patients both in the hospital and in the community. Empirical therapy for MRSA should be considered beforehand when you start the treatment in patients with complicated skin and soft tissue infections. Well, there are different types of therapeutic options available for treating these infections, but among them, Cephteroline has a broad spectrum of activity which can be used as a monotherapy covering MRSA and also several gram-negative pathogens. And this is an indication, good indication for mixed infections. And on the top of that, the safety profile is very similar to the other beta-lactams, which means a quite safe drug. So I'll stop here. Thank you very much. And we will proceed after that. So this is the prescribing information for Zymphora. If you are interested in Zymphora, is the trade name for Cephteroline. And I'll stop here. Thank you very much.
Thank you very much, Professor Akova. I thought you really covered quite a lot of breadth, and then you actually went to details and of the new drug, Cephteroline. I'm going to just remind everyone here that please put your questions through the meeting platforms, and we can discuss these questions thereafter. Now, we're going to go into the interactive case discussions now, and I'm going to invite Professor Liu to join us, as well as Professor Akova, for the interactive grand rounds and panel discussion session. Now, Professor Liu is the head of physician, hospitalist in patient division, and the attending physician of the infectious disease department at the Far Eastern Memorial Hospital in Taiwan. He's also the adjunct lecturer at the National Taiwan University College of Medicine and the assistant professor at the Far Eastern Memorial Hospital. Dr. Liu received his MD from the National Taiwan University College of Medicine and his MPH in quantitative methods from the Harvard School of Public Health, USA. He has contributed, of course, to numerous publications in the field of infectious diseases and will focus on nosocomial infection and surveillance. So Professor Liu will join us in discussions, and then Professor Akova will actually do a case presentation first. And again, a reminder, there will be live polling. It's not going to sit down and watch the show, but there'll be live polling. Share with us how you think the management should go, and then select your option and submit. I'm going to ask Professor Akova now to actually present your first case study for today.
Thank you very much, Professor Leong again. I have a short case presentation just to emphasize what I have talked so far. So this is a real case which we recently treated. Actually, the patient is still in the hospital. So I'll give you some details what we have done so far. So this was a 68-year-old diabetic male. He was a doctor as well. Interestingly, he developed multiple itchy maculopapular lesions in his lower extremities 2 days after an mRNA SARS coronavirus 2 vaccine administration. So here are the lesions. These were all developed after the vaccine administration. Within a couple of days, they were itchy. sizes are different, and one of the largest lesions at the right knee. So this is another lesion. As you see here, there's some necrosis on the top of it. Well, this lesion, actually, I'm going to tell you about the history. A year ago, he was diagnosed with malignant melanoma, a local lesion, and this was excised. So on the excised side of this lesion, there was also this itchy lesions on the top of that as well. So at the same time, he developed fever and severe pain and the swelling of the right knee, as I showed the picture, after 20 days of rash. So the rash first appeared, and then the fever and the severe pain and swelling. So he was admitted to the hospital, and there was an MRI of the right lower extremity. And here is the MRI. So you see on both sides, but particularly on this side, there is air in the tissues in different layers, and there are small abscesses throughout the muscle tissue. Oops. The patient actually has been on insulin therapy for type 2 diabetes mellitus for the last 15 years. As I said, during the previous year, there was a lesion on the lateral surface of the right leg, which was biopsied and found to be a malignant melanoma. This was totally excised with the excision of several ipsilateral inguinal lymph nodes, and there was no further malignant dissemination, so he did not receive any further treatment. However, the only complication was that slight edema on the right leg. Now, as the MRI indicated, several abscesses subcutaneously and in the muscle tissue, the invasive radiology department inserted multiple drainage catheters in the lower femoral region and in the calf. And after that, immediately, there were 600 milliliter pus was drained. We did a gram stain immediately from this pus, and it showed gram-positive cocci in clusters, which was obviously indicating Staphylococcus aureus infection. And we also did a right knee joint aspiration because the knee was swollen, reddish, and painful. However, we did not find any indication that it was a septic arthritis. So apparently, it was a cellulitis over the right knee area surface, and it was a myonecrosis in the calf tissue. So here is a question. This is the initial therapy, initial empirical therapy. If you were treating this patient, what would you prefer as your initial treatment? Could it be a MSSA treatment, only a first-generation cephalosporin like cefazolin, or a beta-lactam/beta-lactamase inhibitor combination, sulbactam, ampicillin? Or would you think it might be an MRSA, then you would start a glycopeptide antibiotic like vancomycin or teicoplanin? Or you can give a broad-spectrum anti-pseudomonal beta-lactam/beta-lactamase inhibitor combination, piperacillin-tazobactam, for example. Or you can add vancomycin to piperacillin-tazobactam to cover MRSA as well as gram-negative bacteria, or you would give monotherapy with Cephteroline. So can we have the poll, please? I can't see, but are we having the questions? Now, as I see polling in the audience, and I can't see the results, but I'm not sure whether they are showing the results on site. Anyway, I think we should not wait longer so as not to waste our time, because Dr. Liu is waiting. Okay. Well, I mean, you remember that the MRSA should be covered, particularly if you are in the eastern part of the world, because the incidence would be more than 50%. And in my country, on the slide set that I was showing a map, Turkey was not included, but in my institution, the rate is more than 50%. So I would cover MRSA normally for that. And since it's a diabetic patient, and there might be some mixed infections as well. So what we did, we started piperacillin tazobactam plus vancomycin as the initial therapy. Well, actually, these were the attending physicians. It's not us. So when we were consulted, the patient was receiving piperacillin tazobactam plus vancomycin. And at 72 hours, the culture grew only MRSA, nothing else. However, there was a problem. The vancomycin MIC was 2 microgram per ml. Now, this is the second question. Would you modify your treatment? And if you are going to modify, how you are going to modify it? Well, you could say no modification. I would continue like that. I would still cover the combination therapy, or discontinue pip-tazo, continue with vancomycin despite the MICs is high. You could switch to linezolid or daptomycin or Cephteroline. So can we show the poll and then get the results? Probably we are not going to see the results, but I'll just wait for a while. Excuse me. Well, okay, I think we should go. I can't see the results, but I don't know what was the answer. I don't know whether any of you are seeing the results. Maybe only those people on site. Well, actually, I mean, as I already mentioned, that there should be a concern about the vancomycin MIC since it's going too high. And I believe Dr. Liu is going to comment on this as well in his presentation. So you could switch to linezolid or daptomycin, but each of these agents have their shortcomings, as I already mentioned in my presentation. So Cephteroline could be a good alternative here, both covering gram-positive MRSA and gram-negative bacteria. So what we did, we actually switched to Cephteroline to 600 milligram BID, and we withdrew all these catheters after 3 weeks of therapy. At this time, there was no drainage detected, and we treated this patient up to 6 weeks because it was a severe myonecrosis, and the patient was confined to the bed, and he received these antibiotics. And today, his rehabilitation is ongoing, although we withdrew all the catheters and stopped the treatment. So this is, as you see, this is a very simple case actually, but indicating that MRSA might have some catastrophic consequences in those patients with, uncontrolled diabetes and underlying severe diseases. And then if you cover properly in your empirical therapy and start your therapy early, at the same time drain all those abscesses, the success rate is going to be very high, but it's going to be a painful and a long duration of therapy. I think I'll stop here, and this is again the prescribing information, as I already mentioned, and I will leave the floor to Dr. Liu, after whom we can discuss. Thank you very much.
Thank you. I think that's a fascinating case. I mean, we do look after many of our medical colleagues, and when they do come up with an infection, they seem to end up very unusual. And 600 mils from the muscle layer is really quite impressive. I'm going to have Professor Liu next, Professor Chia-Ying Liu, who's going to present the second case. Now, you may have questions. Remember, ask them in the Q&A. We're a little sorry about the polling earlier, but we're going to try to do better this time round. So Professor Liu now is going to share with us. And again, there will be polling questions, and feel free to ask anything at all regarding the presentation or cSSTI in general. Professor Liu?
Hi, thank you, Dr. Leong. Thank you, Professor Akova. It's my great honor to join this symposium. I'm Dr. Liu from Taiwan. I'm an infectious disease specialist. Because of the time constraint, I think we will start here. This is the disclaimer, this is the disclosure, and this is a 70-year-old female. She was sent to our hospital because she had some right leg erythema, swelling, and tenderness. As you can see during the ER stay, her erythema and swelling progressed and extended to her knee gradually. According to medical record, she had some underlying disease, including hypertension, diabetes, and some chronic kidney disease in very early stage. Her diabetes was controlled with OAD, and which was quite good. Her baseline HbA1c was less than 7.0, and her TOCC history was unremarkable. And while she was staying in our ER, there was no fever, hemodynamic was stable, and other physical examinations are unremarkable. And you can see the initial lab reports. You can see she had some leukocytosis, neutrophilia, and you can see some immature white blood cells here. Her renal function was still okay as compared to her baseline, but you can see her CRP level is very, very high. And her HbA1c, as we have told, her HbA1c was less than 7.0. It means her baseline diabetes control is still okay. So here comes our first question. What kind of diagnostic procedure would you perform in this patient? Consider her current physical finding, her stable hemodynamics. Would you do blood cultures? Would you do skin swab culture? Or would you do puncture biopsy? Or would you arrange a CT scan? Or just consult a surgeon? Or just treat it? You don't need to do anything. Please vote. So I think there should be some music on site or something, I guess. Okay, because of time constraint, so we will proceed briefly. To culture or not to culture, basically, it should depend on the severity and the type of her skin and soft tissue infection. If your patient has an uncomplicated and skin soft tissue infection, basically, the culture or blood cultures are deemed not so necessary. But if you have some purulent skin and soft tissue infection, or you have some ulcerative form or even to a necrotizing form, then tissue culture should be done. So for uncomplicated skin and soft tissue infection like erysipelas, folliculitis, or impetigo, basically the biopsy for culture is not so cost effective. So it's not recommended for routine. And if your patient did not have a systemic toxic sign, in a patient with uncomplicated skin and soft tissue infection, the baseline blood culture yield rate is very, very low, approach to zero as compared to a complicated skin and soft tissue infection. So blood culture is not routinely recommended. And for patients with uncomplicated tight skin and soft tissue infection, if you consider there is a retained foreign body or something else, then you will perform an imaging. Otherwise, imaging study cannot help you to determine the prognosis of uncomplicated SSTI. But for patients with complicated SSTI, especially if there was some pus with the purulent form, if your patient is undergoing incision and debridement or a tissue removal, you should do the tissue culture and grandstand from your collected specimen. And if your patient has some systemic toxic sign, blood culture will be helpful. Otherwise, even though patient with some local confined purulent SSTI, if the patient is absent from systemic toxic sign, then blood culture yield rate will be quite low, maybe less than 10%. And if your patient have necrotizing type of skin and soft tissue infection with at least 2 signs of major organ involvement, then all kinds of these septic workup, including the tissue culture, the blood culture, or even imaging study should be done in this more severe form. It is very hard to differentiate patient from cellulitis from necrotizing skin and soft tissue infection. According to some study published in British Journal of Surgery, actually about 70% of patients with necrotizing type of skin soft tissue infection are misdiagnosed as cellulitis during their initial evaluation. Some people will say on our textbook or according to our teacher, we should note if your patient have some purple skin discoloration or if the patient have some bullae or cryptus, you should be aware he or she possibly have the necrotizing type of the SSTI. But unfortunately, most of the patients with necrotizing SSTI, about 70 of them are only presented with symptoms like cellulitis. Only around 20 to 30% of them are presented with a bullae or cryptus or hypotension paresthesia. So it's a specific sign, but it's not so sensitive. So unfortunately, none of the previous mentioned signs are very accurate to diagnose the most severe type of SSTI. Some people may ask about, they have heard about RENEC score. It's a laboratory-based score to differentiate patients with necrotizing SSTI from simple cellulitis. If your patient have the RENEC score higher than 6 or 7, maybe their chance of having necrotizing SSTI are higher than 50 or 70%. Unfortunately, during the follow-up study, actually their sensitivity is not so high, although their specificity are quite good. As compared to our routine study like the CT scan, actually CT scan is much more sensitive as compared to the RENEC score. So it's not so robust. So basically it's a multidisciplinary approach is needed. With the attending physician from medical department and the surgical and the radiologist, they should be collaboratively work together. If your patient have a high clinical suspicion of the necrotizing type of SSTI, you should arrange a prompt surgical exploration with some dense tissue specimen for culture and for diagnosis. So in this patient, although the ER physician tell us she has only cellulitis, they already done some blood culture and there is no pus available. They also consult plastic surgeon and the surgeon said, it seems medical treatment is enough for this patient, so she was admitted to the medical ward. So now here comes the second polling question. What kind of empirical choice would you pick up? The first is ampicillin surfactant plus glycopeptide like vancomycin or teicoplanin. Choice 2, daptomycin. Choice 3, linezolid. Choice 4, tetracycline. Choice 5, Cephteroline. Please vote. So we don't have much time to wait for the results, so I will proceed to our review part. According to the IDSA guideline, this patient belongs to the severe form of the non-purulent type of skin and soft tissue infection. So a gram-negative anaerobic and Mrsa coverage are deemed to be necessary. Unfortunately, according to some previous publication, these patients with the most severe form of SSTI, around 90% of them are getting inadequate or undertreated according to this retrospective data. Because for this non-purulent type, severe type, gram-positive coverage, including Mrsa, and gram-negative coverage are deemed to be necessary. According to the Mrsa treatment guide, the first line choice will be vancomycin. And you can see the loading dose and maintenance dose are quite high for vancomycin. And you need to monitor the trough level in these patients receiving vancomycin therapy because we need to monitor if they have severe form of Mrsa infection. Their trough level should be higher than 15 to 20 microgram per milliliter for this complicated infection. And you can see if this data could be achievable if their Mrsa MIC is less or equal than 1. If their MIC is higher than 2, basically this pharmacodynamic monitoring is not enough. You need to switch to another agent because it's not achievable without toxicity. So according to the Mrsa treatment guide, in addition to vancomycin, linezolid, daptomycin, telavancin, I know telavancin is not available in Singapore or in Taiwan. These are all belongs to the A1 category for Mrsa treatment. But for this patient, since she has non-purulent complicated SSTI, linezolid and daptomycin, they lack the gram-negative ROS coverage. So we need a combination therapy in this patient. So after she was admitted to our ward, we initiate ampicillin plus surfactant and the vancomycin with 15 milligram per kilo every 12 hours, according to the IDSA guideline. But after 3 days of therapy, her erythema range did not regress. And we have checked her vancomycin level. Unfortunately, the trough level is only 9.4. And we already noticed some fluid accumulating under her skin. So we worry about abscess formation. Therefore, we arrange a CT scan of this patient. You can see under her skin, there is a hypodense fluid pocket in her skin and soft tissue. It means there is an abscess formation. So there is clear evidence that our ampicillin sulbactam plus vancomycin treatment, it seems failed. So we consult the surgeon again. The surgeon arranged emergent debridement for this patient, and they noted a huge abscess under her skin. Much pus was drained, and they performed fasciotomy. So since we already have treatment failure, so here comes our third question, the salvage therapy after initial treatment failure. What kind of decision would you make? Would you keep vancomycin but adjust dose, or would you switch vancomycin to another agent like daptomycin or Cephteroline, or nothing else? I would just keep this kind of treatment. What choice would you pick up? Please vote. So we don't have too much time to wait for the voting results. So I will just proceed to the review part. Actually, just like I said, the vancomycin treatment response is depend on the AUC divided by the MIC level. So if the patient have a trough level around 20, the mean AUC will be around 400. So if her MRSA MIC level is equals to 1 or lower, generally this PK target could be achievable. But if her MRSA MIC is higher than 1, for example, 1.5 or 2, or if your trough level is only around 9 or 10, basically the PK/PD target is not achievable. So it will link to a poor clinical outcome. Just like Professor Akova has said, when your patient have vancomycin MIC higher than 1 or 2, basically you will see a poor clinical response as compared to the MRSA with MIC less than 0.5. And some people may say, can I use daptomycin instead? But if your patient, if your MRSA already exposed to vancomycin before, for this patient with heterogeneous VESA, basically their thickness of cell wall will increase and the cation ingredient of the cell wall will increase. Both of these factors will affect the diffusion capacity of daptomycin and reduce its clinical susceptibility. So you can see, according to previous study, the cell wall thickness is associated with higher MIC of the daptomycin and associated with treatment failure. So in this patient with vancomycin treatment failure, daptomycin will not be a good choice. Instead, Cephteroline can retain a good in vitro activity, whether it's MRSA or MSSA. And besides, Cephteroline also has gram-negative coverage ability, including the E. coli, Klebsiella, and other genotype of the enteroepithelial. So according to previous study, the susceptibility of MRSA to linezolid, daptomycin, tetracycline, and vancomycin are excellent. And their susceptibility to Cephteroline are around 95 to 97% around the world. In our local data, only around 7% of the MRSA are associated with higher MIC, but this higher MIC did not indicate a resistance range. Instead, according to our COSI guideline, these MIC are belong to the so-called dose-dependent susceptible. So it means if you meet this patient with elevated MIC, you just need to increase the Cephteroline dosage from 6 mg every 12 hours to every 8 hours. It can overcome the increased MIC in this strain. So in this patient, her culture was proved to be MRSA, and we switched to Cephteroline. And very luckily, after 2 weeks of therapy, her wound improved very much. So we performed a wound skin flap and closed her wound gradually. So the patient was successfully treated with Cephteroline, although she has a very severe form of necrotizing fasciitis. And this is her final diagnosis. She had right knee and right lower leg necrotizing fasciitis, and she had underlying diabetes and hypertension. So in summary, urgent debridement is necessary in this patient with necrotizing type of SSTI, and the Mrsa should not be neglected in this patient. In patient with vancomycin treatment failure, or if their trough level is not achievable, non-glycopeptide option like Cephteroline will be a good choice in this patient. And this is the prescribing information of Cephteroline. Thank you. This is my presentation.
Professor Liu, thank you very, very much. Interestingly, both cases actually had knee infection, well, the skin overlying skin over the knee that's infected, and as all physicians were terrified of septic arthritis, but so far it's turned out fine. I'm going to go do the Q&A. We have questions coming in and keep them coming. So I'm going to start with Professor Akova, and perhaps Dr. Liu can join, Professor Liu can join us with this answer. It's about teicoplanin. Someone wrote in, and I think it's a very valid question. What about, we were comparing Cephteroline with the vancomycin. What about when we use comparing Cephteroline and teicoplanin? This teicoplanin, we don't have to worry so much about the renal issues. Professor Akova, what do you think?
Yeah, thank you very much, Dr. Leong. That's an excellent question, actually. Well, teicoplanin is also a glycopeptide antibiotic. Although side effects have been reported less than vancomycin, it is still a glycopeptide, and it might have still those side effects as well, like red man syndrome, etc., etc. But more than this, teicoplanin is only active against gram-positive bacteria. So if you are treating MRSA, that's fine. But if you are treating something else, a mixed infection, teicoplanin has no intrinsic activity. And also, one thing is also distinguishing the teicoplanin from vancomycin. Teicoplanin blood levels is not readily available. I mean, not many centers you can measure teicoplanin blood levels, so it's going to be difficult to maintain the treatment and adjust your treatment according to the blood levels. Maybe Dr. Liu would like to comment as well.
Hi, I'm Dr. Liu from Taiwan. You know, teicoplanin is also one kind of glycopeptide. So the MIC creep issue of vancomycin was also noted in teicoplanin. So if you keep a lot of different copies of the antimicrobial guide from United States for a couple of years, you can see the recommended teicoplanin dose before maybe 2018 is 4 to 6 milligram per dose. But right now, we already shift to a higher dose. If you are treating a patient with MRSA with teicoplanin, you should at least use 9 to 12 milligram per dose with 3 doses of loading dose, because MIC creep of teicoplanin was also noted. So if you want to use teicoplanin to a patient with vancomycin treatment failure, and if your microbiology lab already proved that his MIC was already elevated, then I don't think teicoplanin will not be a good choice, because the MIC of teicoplanin will be increased as well. So I think an alternative agent like daptomycin, like linezolid or Cephteroline will, because they have different kind of antimicrobial mechanism, it will be a better choice as compared to teicoplanin. But if you insist, if you really very like teicoplanin, you should use a high dose. It means at least 9 to 12 milligram per kilo per dose. Yes.
Dr. Liu, I totally agree with you. I'm going to add in the fact that teicoplanin is not freely available in many countries. And what Professor Akova has said earlier on, that you may not be able to measure. And third one is, I find that glycopeptides in general is the action actually to kill Staph aureus. I just find it much slower compared to the other drugs like Cephteroline or as well as the penicillin group class of drugs. I'm going to jump into the next question here. It's about diabetic foot infections. Can Cephteroline be a first-line therapy for diabetic foot infections, since they're mostly complex infections with a variety of bacterial pathogens? Or do you need to combine Cephteroline with other drugs, or just Cephteroline is good enough? Both our patients have diabetes. Perhaps may I have opinion from both of you?
Well, maybe I can start. I mean, this is another excellent question. Diabetic foot infections are mixed type of infections. And when we say mixed type of infections, both gram-positive and gram-negative bacteria may be involved. And there is a full smell from the lesion, you should suspect about anaerobic infections as well. So in that case, if you remember the in vitro spectrum of activity of ceftaroline, ceftaroline has excellent activity against MRSA and a variety of gram-positive bacteria, including ESBL negative gram-negative bacteria like ceftriaxone. So in that case, those patients coming from outside the hospital in the outpatient setting, ceftaroline alone can be used as the empirical therapy for diabetic foot infections. But if you suspect or if you culture ESBL positive bacteria, in that case, ceftaroline would not be enough to cover all these bacteria. Well, there is not much data about combination of therapy for ESBL bacteria. Well, in that case, you have two choices. You can, well, start with a different antibiotic, which is active against ESBL positive gram-negatives, like ertapenem, for example, can cover ESBL gram-negatives, but you have to add an MRSA molecule to this one, so it should be a combination therapy. Or there are some in vitro data, ceftaroline plus an aminoglycoside could be a good choice as the combination therapy for covering gram-negative ESBL positive bacteria, and ceftaroline is covering the rest of the gram-negatives and MRSA. So these are the alternatives. And if there is, of course, an anaerobic infection, you have to add an anaerobic agent to ceftaroline therapy. Could be metronidazole, for example. This would be a good choice. So it depends what type of microorganisms you are suspecting. But if there is ESBL positive bacteria, you should keep in mind that ceftaroline would not cover these microorganisms.
Dr. Liu, do you have any other comments to add?
Yes, I can add on some point. Traditionally, for a patient with diabetic foot, generally we need gram-positive, gram-negative, and anaerobic coverage. So usually prior to ceftaroline, most people will pick up, for example, piptazole plus vancomycin. But according to some recent publication, if you use piptazole plus vancomycin together, the chance of the acute kidney injury will increase significantly. And besides, because vancomycin, they have very poor penetration. If your tissue have some peripheral vascular insufficiency, the tissue concentration compared to the serum plasma concentration, maybe it's around 10 or 20%. So the treatment response of piptazole plus vancomycin will be poor in these patients with peripheral vascular insufficiency. Besides, their chance of AKI will increase significantly. So it's no longer such a very good option. But if you want to use ceftaroline for diabetic foot, it has some limitation. First, it cannot resist the ESBL. So if your patient was culture confirmed with ESBL, you need to switch to another agent. The second limitation is ceftaroline did not have an anaerobic activity. So if your patient, their tissue culture already has some anaerobic pathogens, you need to add something else like metronidazole or clindamycin. It depends on what kind of pathogen do you have. But ceftaroline has one advantage. It has very excellent tissue penetration. So some of the review slides are removed, but actually, as compared to patient with CKD or diabetic foot or patient with peripheral vascular insufficiency, their clinical treatment response rate is still higher than 70 or 80%. So it means they have very, very good tissue penetration. So as compared to our traditional piptazole plus vancomycin regimen, it has a good renal protection effect, and it has very good tissue penetration. So if your patient are infected with wild type E. coli or KP plus MRSA, I think for these patients, ceftaroline would be an excellent choice. But if your patient already have anaerobic pathogen or ESBL producing pathogen, you need to switch to another antimicrobial agent. Yeah.
I've been asked to wrap up very quickly. I think we had a great session. There are actually more questions, but you can't deal with them. I want to thank all the speakers for sharing their cases, and I think they were fabulous cases, very practical. We talked a little bit about soft tissues infections. We talked about the prevalence, the risk factors, and the risk of MRSA, which is really quite common in the region as well as all over the world. Going forwards, we expect to see a lot more MRSA, and the treatment options are no longer just vancomycin or teicoplanin, but we do have a lot more agents, and Cephteroline is a good alternative. We looked at the pros and cons of using the usual vancomycin as well as the newer drugs such as Cephteroline. Going forwards, I can tell you that Cephteroline is actually a very good drug. I've used it very often in many patients, and we've seen the improvement which we see with the use in the skin and soft tissue infection. It goes down to you trying it and seeing it for yourself if it makes a difference compared to the usual comparators like vancomycin or teicoplanin. With this, I'm going to end the talk. We are finishing exactly at 1 hour. This has been a great session. I'm very thankful to the speakers. I'm very thankful for Pfizer for sponsoring this symposium. You guys stay safe. All the best. There is the feedback. I was reminded. Do the feedback QR code, scan it, and give us your feedback survey. Thank you very much.
Thank you. Thank you, and have a nice